Welcome back, students. We have officially made it to part 141 of our 150-part IPDRG Masterclass, which means we are launching our final 10-part Capstone series. In part 140, we got into the weeds on mastering AI, automated encoder algorithms, and machine learning in DRG grouping, but today we're shifting gears to the executive level. Before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, today, we're taking something that usually just sits quietly in the back office, inpatient DRG management, and we are elevating it into a critical C-suite strategy for a hospital's financial viability and regulatory compliance.
So here is our game plan for today's Capstone lesson. We're looking at executive IPDRG strategy, clinical documentation integrity, enterprise audit architecture, revenue integrity metrics, and finally our summary and executive takeaways. Basically, we're going to start way up at the strategic peak of the organization and work our way right down to the foundational workflows.
All right, Section 1, Executive IPDRG Strategy. Let's get into the strategic imperative. When you're sitting in the C-suite, say you're the CFO, the CMO, or the VP of Revenue Cycle, you have to align with your clinical and coding directors to form a united front. And as a team, you have to constantly ask yourselves this: what actually happens when our documentation and coding don't accurately reflect how sick our patients are? What is the true cost of non-compliance? You're basically trying to balance compliant optimization against the very real threat of clawback penalties and corporate integrity agreements. And this comparison brilliantly illustrates the high-stakes balancing act that executives face every single day. On one side, you have the existential legal threat of upcoding. Upcoding isn't just a simple mistake. It's a massive fraud risk that violates the False Claims Act and brings recovery audit contractors, or RAC audits, right to your front door. But then, on the flip side, you have undercoding. That's a massive revenue risk. It causes loss reimbursement and drops your hospital's case mix index, or CMI, which makes your facility appear way less complex than it actually is, leading to severe financial instability. Now, what's really interesting about these Medicare rules is the focus on ethical optimization. That is the goal here. It means making absolutely sure the hospital is compensated fairly for the complex care it provides, but without crossing the line and triggering government audits. Documentation integrity means every single code assigned is thoroughly supported by the physician's clear and unambiguous clinical documentation. No guesswork allowed. Moving right along to Section 2, Clinical Documentation Integrity. To protect our revenue, we need a strong structural foundation. Think of clinical documentation integrity, or CDI, as the vital bridge between the clinical floor, where the doctors are, and the billing department. It is the process of reviewing medical records to ensure they accurately reflect the patient's severity of illness, risk of mortality, and the intensity of services provided. CDI steps in when documentation is unclear to protect your revenue integrity. So let's look at how they do this. The crucial point here is that a compliant physician query must be purely objective and non-leading, just like this textbook example right here. Notice how it completely avoids pushing the physician toward a higher-paying diagnosis? If you ask a leading question, like practically begging the doctor to diagnose acute blood loss anemia just to secure a higher payout, you are exposing your entire hospital to massive compliance risks. And you have to remember, the CDI workflow operates with extreme urgency. Why? Because the billing clock essentially stops the moment a query is issued to the clinician. Step 1, the specialist reviews the documentation. Step 2, they create a compliant query. Step 3, that query is routed directly to the provider. Step 4, the provider responds, which becomes a permanent part of the record. And finally, Step 5, the coder updates the finalized coding. It has to be a fast, seamless loop.
All right, Section 3, Enterprise Audit Architecture. Let's build out the scaffolding.
With the documentation clarified, we need to ensure we only bill for what's actually there. Before a claim ever even reaches a payer, we establish targeted pre-bill workflows designed to catch errors. We're applying automated clearinghouse rules. We're validating medically unlikely edits, or MUEs, basically checking if a claim makes clinical sense. We check present on admission completeness, match diagnoses to procedures, and prevent duplicate lines. This is your absolute first line of defense.
To do this effectively across an enterprise, health systems combine two main methodologies. Retrospective audits allow you to review completed charts post-submission to identify root causes of denials and track systemic trends. But you also need prospective audits. This acts as an aggressive gatekeeper. You review high-risk, high-dollar claims, like complex surgical cases or sepsis, before submission, so you prevent immediate revenue loss and don't have to chase the money later. And 95 is the magic number here. Maintaining internal coding accuracy thresholds at or above 95% is the golden benchmark for unbiased compliance and financial validation. To hit this reliably, organizations establish rigorous internal peer review standards and often leverage independent third-party external audits to make sure their numbers are rock solid.
Next up, Section 4, Revenue Integrity Metrics. This is where we bring all this data to the board. We take all that foundational audit data and translate it into actionable C-suite dashboards. Without these key performance indicators, executives are essentially flying blind. You need to be tracking things like your first pass clean claim rate. You need to know your days in AR. You have to monitor your DRG denial rate. And a huge one, your query response rate, which tells you how responsive your clinicians actually are to your CDI teams. These metrics communicate your true financial exposure.
Now, executives also closely track productivity norms, as you can see mapped out here. But listen, they must always prioritize quality over speed. It doesn't matter if an experienced coder can fly through 15 complex charts a day if they are making mistakes. A single miscomplication can literally cost thousands of dollars or lead to a devastating payer denial. Accuracy is everything.
Finally, Section 5, Summary and Executive Takeaways. Let's distill all of this down.
Here is exactly what you should take away from this executive overview. First, IPDRG is absolutely the financial lifeblood of the hospital. Second, CDI prevents revenue bleed and fraud simultaneously. It's doing double duty. Third, your pre-bill and post-bill audits form your core defense architecture. Fourth, any volatility in your case mix index directly reflects gaps in clinical documentation. And finally, KPIs are the only way to translate technical coding into real C-suite strategy.
I want to leave you with this final thought to consider for your own health system. Is your revenue integrity architecture robust enough to survive the next major compliance audit, or are you leaving your financial viability entirely up to chance? Well, that wraps up Part 141. Next time, in Part 142, we are diving into our Executive Capstone, High-Risk DRG Clinical Audit Protocols, covering sepsis, cardiac, and surgical DRGs. It's going to be fantastic. And hey, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. See you in the next one.